Hello, welcome to Studental. My name is Dr. Priya Patil Chaudhary. I am a prosthodontist and today we are going to see what are dental laminate veneers. So let us see. We will see what are the indications, contraindications, advantages, disadvantages of laminate veneers. What is the treatment plan phase, instrumentation, the types of different laminates, that is composite laminates, acrylic laminates and porcelain laminates. The preparation design, which has 4 designs, that is no preparation design, facial preparation, third is facial and incisal overlap preparation, fourth is facial and incisal butt joint preparation. We will see all this in detail. Then what are the preparation guidelines for laminate veneers? The stratification concept, the tooth preparation, then impression and gingival retraction, temporization, lab communication, trial of laminates, and then cementation and finishing of the prosthesis. So let us see. As the name suggests, laminate veneers. They are etched cast restorations used to improve color of stained teeth, alter tooth contours of mishapen teeth, and close interproximal spaces. In photo, we can see the laminate veneer. So what are the indications? When we have discolored teeth, when we have enamel defects, the enamel defects means when fluorosis case is there or amelogenesis imperfecta case is there, we can see the white chalky spots on the enamel surface of teeth, which does not look aesthetic. In severe cases of fluorosis and amelogenesis imperfecta, the yellow and the dark brown stains are also visible. These can be altered using dental laminate veneers. Then when we have diastema closure, for diastema closure, that is midline distance between the central incisors or midline gap, can be closed using dental laminate veneers, and it is one of the most popular way to close this gap. Then when we have malposition teeth, when there is malocclusion, when we have worn restorations like old composites or any type of tooth colored restorations which are worn and they are discolored and they are not looking aesthetic. Due to aging, the enamel and the some part of dentin is worn off and it does not give good aesthetic results. In that cases also we can go for laminate veneers. When we have wear patterns, that is attrition, we can go for laminate veneers. This is a very typical case wherein we have peg lateral, agenesis of lateral incisor. In that case, there is a gap between central and lateral incisor, and in such cases we can give dental laminate to lateral incisor and thereby we can close the gap and we can improve the shape of peg lateral incisor. What are the contraindications? When we have insufficient enamel structure, we cannot give dental laminate. When there are large restorations means when we have more surface of the tooth, more part of the tooth involved in the destruction process, we should consider giving a complete crown rather than dental laminate. Then when we have occlusal interferences, like we have edge-to-edge bite or cross bite. In edge-to-edge bite, what happens is the upper and lower incisor teeth, they bump onto each other. In crossbite also the similar case happens. In these cases there are more chances for dental laminate to debond and hence we should avoid giving the dental laminate in these cases. Remember, when we have edge to edge bite, that is when central incisors are bumping onto each other in the centric relation or in the lateral excursions, and we have crossbite. Then when we have darkly stained teeth, darkly stained teeth means when we have extremely brown original tooth. In that case, changing the color using just thin laminate veneer won't do. The aesthetic results which we are expecting from it, we will not be able to get through dental laminates. In such cases, we should consider giving a complete crown. Thereby, we will get the sufficient thickness of ceramic in the complete crown, and since we will have a good thickness of ceramic incomplete crown, we can achieve good aesthetic results due to the more thickness of ceramic. So when we have grossly worn occlusions, like in the case of bruxism or clenching, in such cases also the debonding case is more. Then when we have periodontally involved teeth. So what are the advantages? This is one of the most conservative way of tooth replacement. It is minimally invasive treatment method. The shape, position and surface appearance of tooth can be changed. The tooth length, the alignment can be corrected. It eliminates any dysplasia or dystrophy. The color can be improved. The better light transmission is possible with the dental laminates. When we have, in this case, we have better light transmission. The tissue response with the dental laminates is good. And the speed and simplicity of the process is also one of the advantage with the dental laminate. Then what are the disadvantages? Sometimes over contouring also happens with the laminate because we are not preparing tooth too much. Usually 0.3 to 0.5 or maximum 0.7 millimeter of the enamel structure we are reducing, and hence sometimes achieving the required aesthetic results are not possible with such thickness of ceramic, and hence we have to give little bulky laminate veneers, and hence sometimes over contouring also happens. It requires meticulous lab procedure. Yes, the lab procedure is very good. The dental laminate requires meticulous lab procedure, and untrained lab technicians cannot do justice to dental laminates. A fracture rate is more because the thickness of dental laminate is less, and it has brittle margins because the margins are sometimes feather edge, and dental laminates are more commonly fitted by the any fluoride treatment which patient takes in the future. The more disadvantages are, although we say it is conservative of the tooth structure, we have to do substantial tooth reduction in few cases. Then it cannot be repaired if some damages happen in the use. We have to remake it. It is difficult to temporize because just the facial aspect of the tooth structure is reduced. The color cannot be altered after placement. The placement is difficult and time consuming. Coming to treatment plan phase, the first thing, we have to see the patient's expectations. We have to evaluate what are the patient's final aesthetic expectations with the treatment. Check the contraindications. The contraindications as in if we have the edge-to-edge bite or cross bite or teeth bumping onto each other or the centric contact or the occlusion is such that it will cause debonding of the laminate. The future of laminate is not that good. The prognosis is not good. So we have to see all these factors before we start with the dental laminates. Then we have to articulate the study cast on the articulator. The posterior occlusion should be checked. The protrusive interferences should be evaluated. The lateral interferences should also be evaluated so that there is no undue forces on the margins of the dental laminates. The centric anterior lingual contacts are initially marked. Coming to instrumentation. Recently, there are many commercially available kits available for dental laminate tooth preparation. The typical kit consists of such type of burr kit. In the arrow shown, we can see a typical burr. This is the burr used for laminate tooth preparation. Then in the same kit we have a thin tapered fissure burr. Then we have long tapered fissure burr with the round end. Then we have flame shaped burr, the long flame shaped burr, and then we have the polishing burrs. This is a very typical laminate preparation kit. Commercially, different companies have given different kits, but more or less all the kits contain these basic burrs. Coming to different types of laminates. These are the types according to the material used. So we have acrylic laminates, we have composite laminates, and we have porcelain or ceramic laminates. So let's see. Coming to acrylic resin veneers. The one of the most common use of acrylic resin veneers is we give these veneers for temporary purpose. These are used as temporary means of restoration till the time final dental laminate shows stability. In the past, acrylic resin veneers were considered as one of the final restorations, but due to drawback, it is only used for the temporary purposes because it has a color instability. It absorbs the color, the surface staining occurs very fast, the loss of surface texture occurs very fast, then it has low abrasion resistance, and the bond between the acrylic resin laminate and the composite resin was too weak, allowing the veneer to be removed easily or simply fall off. That's why it is not used as definitive or final processes. Coming to composite laminates. Composite laminates are one of the most commonly used laminates because of its ease of fabrication, and it does not require the lab communication. There are two types in composite laminates: direct laminates, which are done directly on the chair side on the patient in the patient's mouth, and second is indirect composite laminates, which are actually done inside the lab. So let's see composite laminates. Here in the photo we can see, in the upper photo we can see the stained old composite, and in the lower photo we can see the facial surfaces of the central incisors are laminated using composites. So this is composite laminates. Composite laminate can mask dark stains more aesthetically. No anesthesia is required. It can easily be repaired in the mouth if staining or chipping occurs in the future. It is more conservative, that is less tooth structure reduction is required than crowning, usually less expensive than crowning. Color change is possible, not as strong as porcelain laminates, and it has a greater wear than porcelain laminates. Coming to porcelain laminates. Porcelain laminates are one of the best dental laminates present today. It has a good longevity and it has best aesthetic results as compared to composite. Coming to properties, it has a good color stability, the bond strength is better, the resistance to abrasion is there, better inherent strength is present, resistance to fluid absorption is there because it is ceramic, hence there is no fluid absorption or staining with the porcelain laminates, and the aesthetic results are excellent because they are made inside the lab. So let's see what are the different preparation designs. There are mainly 4 preparation designs with the laminate veneers. First, no preparation. Second is only facial preparation. Third is facial and incisal overlap preparation. And fourth is facial and incisal bud joint preparation. So let's see what these are. Here in the photo, we can see different types. So first, no preparation. In this case, tooth is not at all prepared. Directly the impressions are made and the final veneers come and they are added to the tooth structure. But it is less commonly done. Second, facial preparation. Here on the canine, we can see the only facial preparation. On the lateral incisor, we can see facial and incisal bud joint preparation, wherein the facial tooth preparation and the incisal tooth preparation meet at a 90 degrees angle. And third is a facial and incisal overlap preparation, in which some part of the preparation goes towards the palatal aspect of the incisal tip of the tooth. So hence these are different preparation designs. So let's see. From occlusal surface, we can see the canine having only facial preparation. On the lateral incisor, we have bud joint preparation, that is facial and incisal bud joint preparation, in which The facial surface preparation and the incisal surface preparation, they meet at an 90 degree. In third type, that is facial and incisal overlap preparation for the central incisor, some part of the preparation extends onto the palatal aspect of the incisal part of the tooth. Coming to the preparation guideline, we will see the typical preparation designs. So in preparation guidelines for laminate veneers, we have to give defined gingival chamfer lines. Proximal chamfer line should not pass the contact area between two teeth. Here we can see in the upper photo, the preparation or the proximal chamfer line is not passing the contact between two teeth. Then 0.5 to 1 millimeter of facial reduction is achieved. 1 to 2 millimeter of incisal reduction is done. All incisal angles should be rounded. There shouldn't be any sharp line or point angle, otherwise that will act as a point of concentration of stress and it will be detrimental for the future of laminate veneer, as these sharp points or round angles or line angles, there will be more chances of cracks into the prosthesis or laminates. There should be no undercut. The lingual chamfer line should be above or under the centric lingual contact line. Then coming to the concept of stratification. Stratification is the process of forming in the layers. As the name laminate means, the dictionary meaning is overlay, layer, cover. The veneer means a coat or a cover. So basically laminate veneers means cover or a layer or layering. The stratification is the process of forming into different layers. So by giving different layers, we achieve the good aesthetic results in the dental laminates. So we will see what is stratification. The stratification is the tooth, the resin cement and the porcelain veneer must be manipulated precisely for optimum clinical results, and this is called a stratification. A bonded porcelain veneer has three layers. Inner layer, that is the tooth. In the photo we can see the prepared tooth. Then inner layer, the inner layer the tooth, the middle layer is the resin cement and the outer layer is the porcelain veneer. The color of porcelain veneer is achieved by correlating tooth preparation, resin interface and porcelain veneer formulation. Coming to tooth preparation, before starting with porcelain veneering, restoration of all carious lesions, replacement of faulty restorations and eradication of all periodontal disease on the tooth to be veneered is mandatory. Pumice all the teeth to remove extrinsic stain. Occlusal abnormalities should be corrected before starting. Stratification method is employed. Then note the color of the existing teeth to be veneered and lower it by one shade. For example, if the unprepared tooth is A3, then prepared tooth will be A3. Then prepared tooth will be A3.5. Based on stratification guidelines, tooth preparation is done according to whether it is a 2-shade shift or 3-shade shift. Then coming to tooth preparation for maxillary anterior teeth. Determine the location of margin before starting the tooth preparation. Whenever possible, supragingival margin, that is 0.5 mm above the gum, above the gingiva is desirable. Then in tooth preparation, we will see three different types. First is we use diamond wheels of 0.3 mm, 0.5 mm, 0.7 mm like that. These wheels are used for the tooth preparation. In the second way, these three wheels are attached on a single diamond burr. On third part, we have round diamond burrs with different diameters, and in the third photo, we can see the preparation is done. So we will see these tooth preparation types in detail. Coming to the first type, In the first type, we have different wheels of different diameters. To control the depth of facial tooth preparation and remain primarily in enamel for bond strength and reliability of marginal seal, self-limiting depth cutting discs are used. These depth cutting discs permit 0.3 mm, 0.5 mm and 0.7 mm cuts to be placed anywhere on the facial surface. Like this, different depth cuts are given. First depth cut is placed on the cervical 1/3, that is 0.3 mm from mesioproximal line angle to distoproximal line angle at least 3 mm from the cemento-enamel junction. Second horizontal depth cut 0.5 mm is placed mid-facially. Third horizontal depth cut 0.5 mm is placed in the incisal 1/3 of the facial surface, approximately 3 mm from the incisal edge. In the second type, as I said, in many of the dental laminate veneer kits, such wheels are available. In such cases, a single burr is used and run onto the facial aspect of the tooth. It has different wheels of the different diameter. In this case, 0.3, 0.5 and 0.7. So in this case, once these grooves are marked, then long tapered fisher burr with the round end is run onto the facial aspect, and the facial preparation is done till all the grooves are disappeared. So further, gingival proximal preparation. Using a long tapered diamond point with round end, prepare a definitive margin 0.5 mm supragingival to gingival margin. Begin at the height of the free gingival margin and prepare the chamfer margin to the distal papilla tip and then to the mesial papilla tip. Continue the chamfer finish line from the distal papilla tip to the beginning of contact zone far enough lingually. This produces an elbow cut which translates into the wings of the veneer, which will conceal the margin. Like this, the facial aspect of the tooth is prepared. Here in this photo, diagrammatic representation of tooth preparation at the contact zone is visible. We do not cross the contact area between two teeth so that the margin of the dental laminate lies onto the tooth surface and that interface is accessible for polishing and cleaning of the margins. Further, continue the definitive chamfer from the elbow cut incisal word to the incisal embrasure, cutting just labial 0.2 mm to the contact zone. This unprepared tooth structure just labial to the contact is significant because it permits a small separation between the veneer margin and the adjacent tooth. This allows easy access for finishing the cemented veneer. The purpose of establishing the gingival margin before facial reduction is to avoid over-preparation. Then, step of facial reduction is assisted by two round diamond burrs. This is the third way. In this way, we use small diamond burrs of different diameters to give 2 or 3 different cuts onto the facial aspect, and then once these cuts are made, as we saw, the further preparation is done in the similar way using long tapered fisher burr with the round end. For facial preparation, remove 0.3 mm of enamel, that is 0.5 mm for profound change in the cervical 1/3 and 0.5 mm or 0.7 mm a profound change is required from the remaining facial surface. Reduce till the depth cuts just disappear. Round off the sharp line angles. As I said, the sharp line angles into the any kind of tooth preparation act as stress points, and at these stress points, chances of porcelain cracks increases. Check for facial reduction in incisal 1/3 to avoid labellization of incisal edge. Here, this is a typical preparation reduction shown into this photo. For teeth with larger enamel, we consider this as an ideal case with larger enamel. The tooth reduction of 0.5 mm in the cervical 1/3 and 0.7 mm in the remaining facial surface is done. Then teeth with thin enamel. When we have thin enamel or some kind of abrasion is present, 0.4 millimeter is done in the cervical area and 0.6 millimeter is done in the remaining facial surface. For mandibular incisor, wherein we have thin enamel and the overall tooth structure is smaller, 0.3 millimeter in the cervical 1/3 is done and 0.5 millimeter of reduction in the remaining facial surface is done. So the proximal finish line is changed from when we have spaced teeth, when we have diastemas. What we usually do, there is a difference between usual tooth preparation and when we have proper contact between two teeth and when we have spaced teeth like diastemas. The proximal finish line is changed from a chamfer to a long bevel. As here we can see, this proximal finish line is changed from chamfer to long bevel, and this bevel terminates at the lingo-proximal line angle as shown here in the this photo. Coming to impression phase. In case of subgingival margin, gingival retraction is carried out. Impression is made using polyvinyl siloxane impression material or hydrocolloid material. Here we can see the teeth are prepared for laminate preparation. Gingival retraction is done. In upper photo we can see one cord is placed. In second photo we can see for after one cord, second cord is placed. This is two cord technique. And in third photo we can see the lingual aspect of the prepared mandibular anterior teeth. Here in the photo we can see two cords are placed. First cord is removed from the gingival crevice. Then light body impression material is poured onto the tooth surface. Impression is made. Coming to temporization. Once the impression is made, we cannot send patient just like that. We have to give them temporaries. So in this case, there are two ways how we can temporize it. In first way, thin vacuum form acetate shell is trimmed to remove the lingual surface and 1 millimeter along the gingival margin of the facial surface and loaded with light cured polishable resin. Like this, a vacuum form transparent sheet is made onto the cast which is made before tooth preparation. So this vacuum form sheet is already ready while we are operating the patient. So after this, a temporary is after this. Okay, so in this vacuum form sheet, we place flowable composite directly into the facial or internal aspect of the vacuum form sheet, and the area which is of no interest, that is lubricate lingual soft tissue with a thin film of petroleum jelly, that is Vaseline, so that the composite will not flow on that. Once this vacuum form sheet is filled with direct flowable composite, we place this vacuum form sheet directly into the patient's mouth and light curing is done. Spot etching is done. A complete etching is not done onto the on the prepared teeth surface. Then gently place the matrix over the prepared teeth. Light cure each preparation from the facial aspect for 5 seconds and remove the matrix. Since it is transparent vacuum form sheet, the light cure can pass. The ultraviolet light can pass through it and it can cure the flowable composite. Then excess may be easily removed with a bladed instrument. Light cure again for final curing for 20 seconds facial and incisolingual areas. Polish with enhanced cups and discs followed by green rubber cups. So this is how we give temporaries using light cure composite flowable resins. Here we can see the temporary. There is another way. A putty index is made before the tooth preparation. In the lower photo, we can see the intaglio surface of the putty index. In this putty index is prepared scalloped at the margins. Then temporary material comes, commercially there are many materials like Pro Temp or Luxa Temp or many such materials are available which are basically dual coat or self cured composite resins or different types of resins which can be placed into the intaglio surface of the putty index. This putty index is placed onto the prepared teeth. The excess material is removed. It has some working time, it has a setting time. Once the setting time is lapsed, we remove the putty index and the final prosthesis or the final temporaries are onto the tooth surface. Then we remove them, polish them, and we lute them or cement them onto the tooth surface with the temporary cement. Then coming to the lab communication, good coordination between the dentist and the ceramist is must, because fabricating dental laminates is a very artistic thing, and meticulous attention and training is required from the part of technician. So the lab prescription should include the following things: shade of prepared teeth, shade of veneers, color map, cervical, body and incisal part, translucency, opacity level of veneers, veneer surface anatomy, texture, gloss, veneer length, contacts and incisal shapes. Coming to veneer trial, we make 1 or 2 trials with the dental laminates. So in the trial phase, what we actually see is first check the veneer for crack or crease lines. Seat the veneer individually and check for marginal fit. Seat the veneer sequentially on the master cast until all the veneers are in place. An interproximal interference or an overextended margin will need modification. Do not force the veneer in position because they can fracture or crack. We should gently place the veneer into the prepared tooth surface. So coming to final cementation and finishing. In this, first, dentin detecting die is placed after placing of metallic strips interproximally. We use metallic strips interproximally so that whatever the material we are using will not flow onto the adjacent teeth. The dentinal detecting die is placed because we prepare the tooth inside the enamel structure of the tooth, but sometimes the preparation goes and extends till the dentin. So we detect the dentinal surface. Then tooth is washed with water and dentin is stained because we had applied dentin detecting dye. Once the dentin is detected, the etchant is placed only onto the enamel surface. We do not place the etchant onto the dentinal area. Once the etchant is placed, we remove the etchant. The frosted appearance of enamel is visible here in the photo after the etching. Then application of dentin or enamel conditioner or bonding agent is done, just like we do for composite resins. Then cement is mixed and it is placed into the intaglio surface of laminate veneer, and then laminate veneer is placed or seated onto its place. So cement is mixed and seating of veneer by means of incisofascial pivot is done. So what is incisofascial pivot? Incisofascial pivot is actually the way how we hold the laminate. We cannot directly hold the laminate in any inadvertent way. We have to use it in inciso and facial direction so as it will go and fit into the place. So complete seating of the laminate in the position we can see in the photo, and excess cement is extruded. Once the laminate is in its final position, the excess cement will overflow. Then light curing is done for 3, 4 or 5 seconds so that partial setting of the resin cement happens. After the partial set of the cement, we remove that excess cement from margins with a thin bladed instrument. After that, a thin metal strip is drawn lingually to remove excess cement interproximally. All the excess cement which is flown onto the gingival margins interproximally, all excess cement is removed because it is now partially set. The completely set hard resin cement is very difficult to remove. Hence, partially set excess resin cement should be removed before we finally cure the resin. So then excess cement removed with a scalar and diamond coated abrasive strip used to remove interproximal flash. Then final light curing is done in this manner. There are few aesthetic considerations when we are giving dental laminates or any type of processes for front region. So in the aesthetic consideration, the first thing is that the prosthesis should be located in the center of the face. It should be perpendicular to the interpupillary line. Then maxillary central incisors are the most important determinant in the creation of a smile. Maximum length is 70% of the distance between the upper and the lower lips. Coming to gingival embrasures. Gingival embrasures, they reduce in volume in a posterior direction. As we go from front to back, we go from anterior to posterior, the embrasure size decreases. So always remember to reproduce these aesthetic considerations into the final prosthesis, be it laminate or any kind of crown. The gingival contours, they are nicely scalloped with the lateral crest inferior to central and cuspid. The incisal embrasures become larger and wider posteriorly. As we go posteriorly, the incisal embrasures, they become larger and wider. The maxillary incisal edge contour follows the curvature of lower lip. So, creating a smile, we should make sure that the maxillary incisal edge contour follows your lower lip line. So, to conclude, laminate veneer is a conservative alternative to full coverage for improving the appearance of an anterior tooth. It is one of the most popular restorations of aesthetic dentistry because of this reason. In university exams, dental laminate veneers or laminate veneers comes as short answer question, and the preparation guidelines for dental laminates also can be asked as a short answer question. In vivas, usually stratification concept can be asked. Thank you.